The heart failure program at the Christ Hospital spans a broad spectrum of interventions. And the reason is because heart failure is a very complex, very varied disease with many different reasons for having heart failure. Patients are different, they react differently. So you can't just have a very straightforward, linear way of taking care of these patients. Heart failure has to involve multiple specialties in a multidisciplinary fashion. So what we've done at Christ Hospital and Ohio Heart is to try to design a program that reflects that complexity. So, for example, in the office, we'll have the heart failure program, which includes heart failure specialists, cardiologists, and in communication with primary care physicians. And they're supported by the nurse practitioners within our practice that specialize in heart failure and will pay attention to particularly the educational aspect of heart failure. And these patients are cared for longitudinally in conjunction with the primary cardiologist. So they are seen a little more frequently. Their medical regimen is poured over more carefully, I think. And their device use, defibrillators and pacemakers and those kinds of things, are a little bit more intensely observed as well. Now, if these patients then decompensate and end up in the hospital part of the heart failure program takes over. And that includes the Carl and Edith Lindner Center for Heart Failure Treatment on the 7th floor of Christ Hospital. And there, you also have a multidisciplinary team. The nurses there are focused on heart failure. They've been trained and they are interested in heart failure. And they do the types of things that most floors find very difficult. For example, weighing every day, keeping very close track of your fluids, and actually looking at what you're eating and what you're putting out. That's actually very important and very difficult to do. And they do that very well there because that's their focus. Other things that are offered through that floor includes education that goes on a regular basis with almost every single interaction with the staff there. But also, you know, the services that might be available on 7th South, the 7th floor, are not available at other parts of the hospital. One example would be ultrafiltration.
One of the more difficult problems we have in patients with heart failure are those that gain a lot of fluid and gain a lot of weight because the fluid backs up in the heart. And in these individuals, sometimes diuretics, either by mouth or when they're in the hospital by vein, are ineffective in terms of getting that weight and fluid off. And at the Christ Hospital, we have the ability to take this fluid off mechanically through a process called ultrafiltration.
Ultrafiltration can be described as dialysis light. It's not dialysis, but it's a mechanical way of removing fluid through a little filter and a little pump. And the reason this is important is because when patients come in, 90% of them come in because they're full of fluid in their lungs, in their abdomen, in their legs, and they're very uncomfortable. And that's a very damaging condition. It's harmful to your body to have that much excess fluid. So typically what's been done is to use what we call diuretics. So the familiar ones are Lasix, Demodex, those kinds of medicines that use your kidneys to urinate and get rid of the fluid. It's been shown that these medicines actually can be harmful as well. Initially, they might get rid of the fluid, but in return, it can do things to your body that might be detrimental down the line. So this has been developed, this technology, to try to overcome that, to try to remove fluid directly from your veins through a catheter.
The ultrafiltration machine allows us more control over this process. We can specifically dial in a rate of fluid removal per hour and monitor that rate over time. And at any time over the course of their day or hospitalization, we can change this according to how they look on physical exam, and more importantly, how their kidneys are functioning. One of the challenges we face while we try to take lots of fluid off patients with heart failure is that their kidneys start to fail in this process. And the ultrafiltration process allows us a little more control of that process, so we feel we can treat their heart failure and their peripheral edema in a much more controlled and safe manner.
So that's one example of devices and treatments that might be available on the 7th floor. Now, as these patients go home, it's very important to transition these patients carefully to the outpatient setting. You can't just say, go home and come back in a month. So there is a program that we've developed at the hospital called the Heart Link program. And this is managed by a nurse whose full-time job it is to call the patients and follow up within a week or so of discharge, to go over their medicines, make sure they're plugged into an outpatient setting. So from the hospital side, the HeartLink nurse keeps a database of who goes home and to call them and make contact within a week. Now, as they go home, we make efforts to actually make sure that they have an appointment within a week or two with a cardiologist, primary care physician, somebody who will be able to pick up the ball once they go home. So we've actually called this the transition zone, where a number of nurse practitioners in our practice will see patients within a week and summarize the hospital stay, go over the medicines, make sure everything's going in the right direction. Then the physician sees them the following week or subsequently. So that process of transitioning is very, very important, and studies have been done to show that patients who adhere to that transition actually do better and are less likely to be admitted to the hospital. The research component of our heart failure program forms one of the two pillars of the program design. We felt that the research part of it was about as important as what we do in the clinical realm, where we take care of patients. And the reason is because all the things that we do for these really complex, sick patients are available through research. If it wasn't for others and ourselves doing the research to figure out what works and what doesn't, we would really be taking guesses. So over the last 10 years, we've been very active in doing clinical research, research that tell us how to use diuretics better, how to use ultrafiltration better, how to use devices better, and what types of patients might or might not benefit from it. And we've published extensively on these matters over the last 10 years, and I think have impacted clinical care throughout the country in some of these matters. So some of the highlights include how to use a defibrillator in patients who might be at risk of sudden cardiac death, how to select those patients out, how to use ultrafiltration, and how fast to run it, how slow to run it, when to start, when to stop, and other uses of pacemakers to try to prevent dilation and development of heart failure. So these are some of the things that we've been at the forefront of that have been very exciting for us personally, but also for us to be able to better define what we do for patients. And actually makes us better, because we're always thinking about what's coming around the corner. We can be more creative about how we take care of patients. And I think really something that keeps us going, keeps us excited and engaged, and doing more than the usual.